So good afternoon, everybody. We all know that there have been several refinements in retinal surgery, and our outcomes have gradually, become better and better. And now we are basically pushing the limits. We are doing surgery in cases that earlier we would have written in the file best left alone. So now this course basically is dealing with the panel's approach to handling extreme retinal pathologies and how we can achieve the best possible outcomes. And we're going to be talking upon difficult case scenarios in retina, that is the recurrent retinal detachment, severe cases requiring retinectomy, advanced PDR, severe trauma, fulminant endophthalmitis, and of course, pediatric retinal surgeries. So I hope everybody would enjoy the talks. It's a wonderful panel that we have, a very experienced surgical panel. And I think we can all look forward to the talks. And I would now begin the course by inviting Dr. Dilraj to talk about retinotomies and retinectomies. Dr. Dilraj, please go ahead.
Thank you. So good afternoon to everybody. And I am going to talk about retinotomies and retinectomies. And basically, the idea is to discuss when to do a retinectomy or a retinotomy and how to perform it. So this talk over the next 10 minutes is going to briefly discuss history and basics of a retinectomy, when to perform it, review some surgical videos, discuss what's the role of adding a scleral buckle in such cases, and then what are some of the causes of a recurrent detachment after you've performed a retinectomy. So I'm sure as many in the audience are aware that retinotomy or a relaxing retinectomy has been around for almost 40 years and was originally described by Bob Malcolmer as a way to achieve complete mobilization of the retina, initially in cases of incarceration following trauma. So when do we perform a retinectomy? So the idea is that a retinectomy is not a substitute for adequate membrane removal in cases with proliferative retinopathy and recurrent detachments. The idea is that when you have circumferential retinal shortening or you have radial retinal shortening, you may need to perform a relaxing retinectomy in order for the retina to lay flat. And the idea is we want to perform a retinectomy that is large enough to achieve that purpose, and that does involve extending into the normal retina as well. So there are also cases where you may not necessarily need to perform your typical SMILE inferior 180 retinectomy, but a more localized retinectomy may be adequate. And these are areas where the area of contraction is not released after the initial membrane peel, and the retinectomy in that case needs to extend anterior again into the unaffected retina. So what about cases of a localized retinectomy or a retinotomy? These are cases where if you have focal retinal incarceration, for example, you have a very dense star fold that is adherent and with extensive intrinsic contraction, or there is an area of trauma with the retina incarcerated, you may be able to get by performing a localized retinectomy in those cases. Another situation where a retinectomy is helpful are in cases where you have rolled edges in a giant retinal tear. So when you have a large retinal tear with rolled edges that prevents complete unfolding even under perfluorocarbon, you may want to trim the edges of the tear in order to extend the natural retinectomy that is performed, and then also similar to other concepts in retinectomy, extend it a little bit into the healthy retina depending on the position of the tear. One of the important points to remember when you're performing a retinectomy is the importance to avoid slippage. Now, slippage occurs when your retina is not adherent to the RPE where it needs to be, and therefore will slip posteriorly during the case. So there are various strategies that can be adopted to avoid this. And one involves, these are cases where perfluorocarbon is essential in order to get the retina to lay flat and to achieve that at the end of the case. So you can try to avoid slippage by carefully drying the edges of the retinectomy while performing your fluid air exchange. And this is really, these are really cases where meticulous drying of the edges all along the edges of the retinectomy and being patient in doing so helps. The other option in such cases is to perform a direct exchange where you fill the eye with perfluorocarbon and then exchange it for silicone oil. And that can be done passively, where you let the perfluorocarbon vent as the oil is injected, or actively, where you're simultaneously injecting silicone oil and actively aspirating the perfluorocarbon. So let's look at some surgical videos. So this is a relatively young female with a macula involving retinal detachment, hand motion vision, has undergone a buccal vitrectomy with gas previously that you can see has failed. So these are cases where, again, you need to be generous about performing lens removal or at least rendering patients pseudophakic if they haven't been done so. Removing the anterior capsule, residual capsule, is important to prevent anterior proliferation. So once your process of removing the membranes is complete by whatever method you adopt, including staining, use of bimanual techniques, and then you make a decision about performing a retinectomy. So one of the first steps I like to do is to highlight the margins of the retinectomy. You can do so by applying diathermy. You don't necessarily need to apply contiguous diathermy, but at least to the vessels that are extending across the margin. Then the next is to cut the retina. You can use scissors, but these days with our small gauge vitreous cutters, they are very effective at performing a controlled cut of the retina. And by reducing the vacuum, you can really do this in a controlled manner. This particular case had retained perfluorocarbon subretinal that was removed. Now, one of the things I wanted to highlight in this video is that we went ahead and performed a 360-degree retinectomy. And this is something that you want to avoid before you have stabilized the retina. And you'll see why in just a minute. Because as we're trying to place perfluorocarbon now, we're struggling with getting that to lay over the retina. And in fact, the retina just slides over to the side. Part of the reason for that is that the posterior funnel of this residual retina is still not open. So there's a lot of intrinsic contraction there. So in these cases, if you are in a situation where you've already performed a 360 retinectomy and now your retina is very mobile, you do want to ensure that you've removed all subretinal bands and membranes. And if the retina is still not flattening, you may be able to then go under air and try to get it to flatten as much as possible and then exchange it for oil. But in general, when performing a 360-degree retinectomy, it is extremely important to leave an island that is connected to the anterior retina so that you can maintain orientation of the residual retina, and you can also then fill it up with perfluorocarbon and then complete the separation of the retina. So this is what these patients look like postoperatively. You do see some heme at the edges. This needs to be minimized as much as possible intraoperatively by applying diathermy to the bleeding vessels, and again, watching and carefully cauterizing as much as you can. But they often do reasonably well, as a method of salvage in these cases. You can see this patient at a year out was about 2,400. What about the role of adding a sterile buccal? Now, this seems counterintuitive because if you're going to cut out a large part of the retina, and this applies to up to 180 degrees of retinectomy, then why add a sterile buccal? Now, there are actually some rationale for adding a sterile buccal to support the horns of the retinectomy edges. So again, this has no relevance in a 360-degree retinectomy, but if you're performing up to 180 degrees, it does help to reverse the direction of the vector forces that are perpendicular to the eye wall. And it increases the inward force because the radius of curvature that's caused by the buccal is much smaller than the radius of the eyeball itself, and it provides you that additional support. Now, it is extremely important to remember that if you are adding a buccal for this purpose, the horns of the retinectomy need to be on the crest of the buccal and not the trough. Otherwise, this may do more harm than good. And that is extremely important when you're placing the buccal. There are also some proponents of a primary retinectomy in PVR. And again, this is something that is still controversial. I usually reserve a retinectomy in cases where there has been reproliferation and recurrent detachment. after primary surgery. But there may be some argument that if there is too much intrinsic contraction, then an early retinectomy that is performed more peripherally does lead to good outcomes, because you're able to salvage more of the retina as you're going more peripheral, and you are able to arrest the proliferative process early on. Now, despite your best efforts, retinectomy doesn't always work. And it is important to recognize what are some of the causes of a recurrent detachment after a retinectomy. And the main reasons are there can be fibrosis at the edge of the retinectomy. You may have performed an inadequate retinectomy. And this is something that we discussed earlier, where it's important to always make your retinectomy larger than what you initially plan. And that's why we often refer to the SMILE configuration for a 180-degree inferior retinectomy. And that does involve extending into the healthy retina for about 20 to 30 degrees. You may form a contractile epiretinal membrane over the retina. You could get anterior PVR in the non-retinectomized area. And that's why it's important to remove this area when you're performing a retinectomy. You can get beyond the edge proliferation. And lastly, severe retinal infolding and then recurrent PVR. So let's look a little bit about what these mechanisms look like. So you can get a star fold or a recurrent epiretinal membrane that causes the edges of the retinectomy to lift up, with similar mechanism with a contractile ERM, fibrosis at the edges of the retinectomy, infolding, and then beyond the edge proliferation. So what about fibrosis of the retinectomy edge? This is tangential and occasionally apitraction. And the solution for this is that you really need a nice and clean edge of the retinectomy. And as I discussed, you want to minimize heme at the edge of the retinectomy by carefully applying diathermy wherever there is bleeding. For contractile epiretinal membranes, removing the internal limiting membrane along with the epiretinal membrane is helpful to reduce the formation of recurrent ERMs. For inadequate retinectomy, we discussed that you really need it to be much larger than what you may have originally thought. Otherwise, you may end up with radial and circumferential retinal shortening. For anterior PVR, you need to excise completely the anterior proliferative complex. I prefer excision over applying laser to that residual area. It does remove the tractional element and remove surface contraction. In cases where there are IOLs or there is a residual capsule, you may want to remove that as well. For beyond the edge proliferation, again, it's important to ensure that the retinectomy edge is as clean as possible. Then this is thought to result because of all the growth factors that are sequestering the fluid phase. For severe retinal infolding and recurrent PVR, again, meticulously removing the membranes before you perform the retinectomy. Remember that the last step should be performing the retinectomy. All your efforts for membrane removal need to be before that. The one exception is that if there are subretinal bands and membranes, those can be removed after reflecting the retinectomy. There are some pharmaceutical treatment options that are being investigated, including intravitreal methotrexate that is injected as a series of intravitreal injections. And this is currently in a phase 2 trial by Aldera. And it's also important to recognize other factors, like smoking status and potential role of other anti-inflammatory agents. And with that, since the time is up, I am going to conclude. Thank you very much for your attention.
Abhishek, you're on mute.
Yeah.
Abhishek.
Thank you, Dr. Dilraj. Quite an excellent presentation, and I must compliment you on the illustrations. Very high quality, good illustrations that made the topic quite simple. Now, next, I would like to invite Dr. Darash Shroff for his talk on PVR. Please go ahead, Dr. Darash.
I'm sorry I was late and I've changed the sequence. So actually, at the end of my talk, I'm going to again invite Dilraj to speak, but good seeing everyone today at the panel, and I'll just start off now. So I'm just going to speak on recurrent retinal detachments and what is it exactly? It's a redetachment of the retina after a successful primary retinal reattachment surgery. And although the failure rates have decreased due to advances in surgical techniques, it is a reality that every VR surgeon has to face from time to time. This can occur post a pneumatic retinopexy, post a scleral buckle, or post a vitrectomy. Causes of redetachment include the ineffective closure of the brake at the time of the surgery. It could be happening because of missed brakes or new brakes, or the development of macular hole. But the most common cause is PVR, which is proliferative vitreoretinopathy. How do you go ahead with such cases? Options include a pneumoretinopexy, a revision or addition of a scleral buckle, a vitrectomy, or membrane peeling under oil. So if you have a retinal detachment after doing a buckle, you can either augment, this is something we don't do very often nowadays, but it used to be done a lot in the past, to augment the buckle or modify the position. And with this, some cases you may avoid a vitrectomy. So this was a case which we had done some time ago, and you could see well on the opto's picture, a nice buckle effect, but there's some fluid inferonasally because there was a superior break. This was a phakic 40-year-old patient, so we are not very keen to do a vitrectomy. And this is how the revision buckle was done. So you can see we just added a buckle piece, and this is added in the superinasal quadrant, and this is an addition to the buckle piece already present there. Of course, this was done fairly recently after the surgery, and it helped. And you can see it attached retina after this procedure. Rescue pneumatic retinopexy also has an important role in this study. 100% of the buccal group and 90% of vitrectomy group got repaired with pneumoretinopexy. But the main thrust of our talk today is revitrectomy. So let us concentrate on this and see how to do this in a stepwise approach. If there's a cataract, like Dr. Diraj also mentioned, to get rid of it, it may require a phaco, or you may need a lensectomy. If the IOL is stable, because especially in cases with a lot of anterior proliferation, you may need to remove the IOL. You may need to use a temporary keratoprosthesis if there's a corneal haze, or do endoscopic vitrectomy. Decide the gauge and decide about putting a buckling element. Why put a buckling element? I believe it's very, very useful. It reduces the circumferential and anterior posterior traction. It helps to isolate the peripheral retina from posterior, forming a new, more posterior ora serrata. And it is very useful supporting large or inferior breaks. Spend time on membrane dissection. This is because anterior PVR is more commonly seen in vitrectomized eye. Normally, we find that the previous surgeon or ourselves have left a large uncut vitreous skirt causing it, then move on to posterior PVR, remove the subretinal bands or subretinal silicone oil or PFCL as we saw, do the ILM peeling, role of retinectomy, of course, has already been discussed, and then decide about the choice of tamponade. So this is a case I'd like to go through from the beginning. This is a case which was already vitrectomized, and we can see the oil is removed. We weren't getting a good view, so there was capsular phimosis. So this is just to show you some simple steps can help to improve the view. And when we look in, it's quite horrible. It's like a napkin ring configuration. So we put a chandelier. I think bimanual surgery has revolutionized these procedures now, because with both hands we can do so much more, and it is much more atraumatic. So now we found the cause of this is a napkin ring. And I think we all have done this when we try to pull these bands with one hand and then we leave it, it goes back like a snake goes back in the hole. So this hand upon hand technique is quite useful. And as you will keep seeing in this video, it's not just a single band. It seems to have a lot of tentacles, and removing it is quite a challenge. So fortunately, without resorting to a very large retinectomy or anything like a 180, just by removing off this band, which you can see is now floating around with its tentacle, this helped to settle this retina, and now we're doing laser and feeling much better about it. So I think that's the end of this case. Just a few tips and tricks since we're on this topic. One was a small tip on how to locate an occult break. This lady had a recurrence 2 years post silicone oil removal. There was an inferior shallow RD along with previous laser marks, but no obvious break was seen. We tried to locate the break with the help of Schlerin with a brush needle, but we were unsuccessful. It's a very shallow RD in this case. We thought out of the box and made a 38 gauge retinotomy and slowly injected subretinal brilliant blue dye. As the dye filled the subretinal space, we had a eureka moment. We saw the blue dye emerge from a very tiny temporal break near a laser mark. Once the break was found, we removed the dye with a brush needle, then performed the fluid air exchange and settled the retina. So just something simple in a case which is challenging. The other tip which I'm personally very fond of is the tug of war maneuver, which is very useful for anterior circumferential PVR. So there'll be a video on this.
I like to perform a maneuver called tug of war, based on the shearing force a rope undergoes during the game. We use opposing forceps to tug and shear the membranes gently and relieve the traction without resorting to a retinotomy. See this young, highly myopic girl with circumferential traction bands predisposing to anterior PVR. This maneuver allowed us to bimanually release anterior circumferential traction. We took two forceps at 180 degrees to each other, then pulled and shredded the bands holding up the retina. Once the bands were separated from the underlying retina, they could be safely trimmed by the vitrectomy cutter. As the traction was released, the retina fell back and settled without requiring any retinotomies. With a sigh of relief, we performed laser to the attached retina.
So I think this is another example of tug of war, but I think we'll just skip this slide. And this is something which we published as an original article in the Indian Journal of Ophthalmology, and it was out in the October issue. It's free online if anyone would like to see it. Let's move on to the next topic about membrane peeling under silicone oil. So this is very useful for recurrent retinal detachment with focal lesions of PVR. And here the infusion cannula is connected to the oil infusion, and intermittently we have to keep on injecting oil to maintain the IOP, and focal traction is released by this maneuver. So just a short video on that. So this is a recurrence under oil. And here we can see we are peeling the membrane under oil. We are not getting too much counter traction. So again, we put a chandelier and we do the bimanual dissection under oil. So here the forceps and the scissors are being used. Scissors in the right hand, forceps in the left hand. I think we have to be very patient in these cases, but slowly and slowly we get rid of the membrane, and we do a fluid silicone oil exchange at the end of the surgery to settle the retina and do the laser. So just coming towards end about tamponade. So what is silicone oil? So heavy silicone oil is basically something which has been designed to overcome the disadvantages of routine oil or gas. These are heavier than water tamponades, and they could endotamponade of inferior and the posterior pole in the normal positioning. So these make, there's no need for phase down positioning if you use this. Of course, we use it very, very sparingly, but it has a special use because the surface of the lower retina periphery is what is not normally covered by the tamponade. And this is where the PVR soup, where the mixture of aqueous humor and growth factor accumulates, and invariably we are frustrated by this inferior PVR. So this is very useful in some of these cases. So basically RD with PVR or with open inferior breaks or membranes are the cases we use this, or patients with positioning issues. These are the ones who benefit maximum from this. But please remember, this is not a substitute for doing a good surgery or complete removal of traction. And if inferior and superior tamponade is required, it may not be a good idea. And of course, it is very, very costly and not easily available. So this is a very busy slide. Let me just take you through it. So if we have a recurrent RD and it is post-vitrectomy, and if we've had a oil removal or the gas is gone, then there's only one option, which you can see on the right. We have to do a revitrectomy, membrane peeling, endolaser, oil with or without a belt buckle. But if we have a silicone oil filled eye, then there are certain options we have. So if there's only inferior break with no PVR, we can just add a scleral buckle, or if it is peripheral, we can add a laser. If they are focal membranes, like we discussed, then you can do membrane peeling under oil or a tiny relaxing retinotomy, which Dr. Dilraj said, for the localized area. But if there's PVR subretinal gliosis, or if there's extensive subretinal oil, then I would definitely recommend a silicone oil removal, membrane peeling, manage the lens, use PFO to help you, do as much of a relaxing retinotomy as required, do laser, and re-inject the silicone oil. So I think the Brahmastra has already been discussed by Dr. Dilraj. So thank you very much. And these are my acknowledgement. So I would like to acknowledge Dr. Kunasha and Dr. Dhanashri ma'am also, because this was a part of an instruction course we had given in URetina also some time ago. So thank you, everyone.
Thank you so much, Dr. Dayas. One, for the crisp talk and for finishing well in time. So since we have a couple of minutes, there are 2 points that I would like to engage with the previous 2 speakers. The first is with Dr. Dilraj. When do you plan a radial retinotomy or a radial cut along with your circumferential retinotomy? Let's suppose you're doing a circumferential RR, maybe a 180 degree or maybe even less than that, but sometimes we add a radial cut to it. So when would be the ideal time for it?
Well, the time would be when you're performing your inferior retinectomy or the 360. The situations would be if there are areas more posterior to your intended margin of the retinectomy, where there is incarceration, for example, from a prior retinotomy, drainage retinotomy side, or the patient has had inflammation and their prior chorioretinal scars that you would want to incorporate as a radial incision rather than extending the boundaries of your retinectomy posteriorly. So that is something that you would plan that after removing the membranes as much as you can, if that area of the retina is still not mobile, then you want to incorporate that. Sometimes you may want to do this in situations where you are performing a repeat retinectomy, with the edges, with one of the reasons for failure of a retinectomy primarily performed. In these cases also, after you remove the oil, you'll be able to assess where the traction is. And in such cases, I like to free up the edges of the previously performed retinectomy for revising them. And in some situations, you'll realize that there are areas that are adherent more posterior to your intended margin. And those are situations where you can perform the localized radial incision, relaxing incision.
Right. Excellent. Another thing that I think sometimes when we fill PFCL after doing a RR and your the retinectomy edge is still lifted in the sense that it's not holding. Sometimes you may do a couple of radial to make it flattened out and spread well, almost like a petaloid appearance. Right.
Yes.
Right. With that, we'll go to the next talk. Our next speaker is Dr. Gagan from Shroff Eye Center, and he's going to talk to us about really morbid PDR cases, the really scary PDR ones. Dr. Gagan, please go ahead.
Hi, good afternoon, everybody. Can you see my screen?
Yes, we can. Please go ahead.
Thank you. So after Darius' Eureka moment, I hope we are able to find some Eureka moments in morbid PDR as well. So as far as PDR goes, I think PDR is actually a proliferative vascular vitreous retinopathy. Now, what differentiates it from simple PVR is the vascular connections or the vascular nails, which are basically connections between the retina and the fibrovascular tissue. Along with that is the hemorrhage, which could be either vitreous hemorrhage or even intraretinal, and even the hemorrhage between the vitreous and the retina. Now, the most important part which needs to be recognized in a case of PDR or surgical PDR is vitreoschisis. Now, this is almost always present in cases of PDR which require a surgery. These are the various forms that you could basically see in a morbid case, where you could have a focal, all over elevated hyaloid with fibrovascular tissue, or you could have this typical C pattern, which is extensively fibrous. Then there are cases where the macular part is very good, but you have these anterior, vitreous proliferations which are present. So now the most important part, as I said, was vitreoschisis. Now, why is it so important to recognize it? Now, it is very important to recognize vitreoschisis because being in the correct plane is extremely crucial to the success of membrane dissection. And knowledge of vitreoschisis and the ability to identify it preoperatively and intraoperatively is extremely critical in finding that correct plane of dissection. Preoperatively, we usually use Swepso's OCT to study our cases, whereas intraoperatively, someone could use triamcinolone or the dual dyes. Being in a correct plane makes a difficult case simple, whereas being in the incorrect plane could land you up with iatrogenic breaks and bleeding, which could make the case extremely messy. So I like to just demonstrate vitreoschisis through this animation. So as we all know that in a case of PDR, we have these elevated prolifs, neovascular prolifs, which kind of grow into the vitreous cortex, and then they kind of grow tangentially into a space, and rather creating a space which divides the vitreous into two leaves, the anterior vitreous leaf and the posterior vitreous leaf. And it is very important and critical to kind of, when we see the retina, what we are actually visualizing is the anterior vitreous leaf and not the posterior vitreous leaf. So it's important to kind of acknowledge this fact that, most of the times you would find a vitreosclesis in the case of PDR, and it is essential that we find the right plane or the right plane of entry so as to have a complete membrane dissection possible. I think swept source OCT, which we commonly use to study these cases, I think in this scan also, you can see that very clearly see a split within the posterior cortical vitreous, which is visualized as two distinct hyperreflective bands. So the band which is marked with the green arrow is the anterior vitreous leaf and the vitreosclesis leaf, and the band which is marked with the blue arrows is the posterior vitreous leaf. And it is very critical that we go under this band, under the blue band, right? So we also study our cases. Again, I think I would suggest studying these cases on a swept source OCT if possible, through various cuts and various planes, and kind of visualize, kind of mentally make a picture of the case as to how you would like to enter and which would be the best plane to enter. I think this has also been very well described by Stanga et al., where they have described various morphological and pathoanatomical features of cases of PDR with a swept source machine. However, obviously, swept source preoperative testing is kind of limited to patients with no or minimal vitreous hemorrhage, whereas intraoperative OCT is again a tool which is can be helpful in these cases after removing the vitreous hemorrhage. Whenever we talk about diabetic vitrectomy, I think the following factors do play an important role, which is preoperative anti-VEGF, combining it with the phacoemulsification, infusion pressure, bimanual dissection, and definitely maintaining hemostasis during these tough cases. And I think the tamponade and a very good laser is something very important. Now, preoperative anti-VEGF, I think, is something which we feel is definitely essential. I think there is always a debate whether a more fibrous membrane would ultimately make it difficult to find the plane. But I think with experience and time and patience, I think finding the plane becomes easier, whereas handling very hemorrhagic retina, kind of tackling a bad hemorrhage at that time becomes way more difficult. Combining with phacoevitrectomies, I feel in any case of PDR, I'm not a very great proponent of limited vitrectomies. I think it should be a complete vitrectomy. I think all sort of fibrovascular polyps should be removed and well cauterized. So I think it makes the surgeries, makes the surgeon very not defensive. The person is not at all defensive, and you get a very good view, and I think can do a complete vitrectomy. Bimanual surgery, definitely, because you get excellent control. I think Dr. Reyes has already shown bimanual surgeries in cases of recurrent detachment. I think the same role also goes here. And I think especially in PDR, I think lifting the membrane with one hand and cleaving your way through the plane with the other hand, I think is very essential. Also, one technique of coagulation of bleeders, which I'll be showing later, can be done with a bimanual technique. So this is basically mostly in cases of normal PDR vitrectomy, you would find this plane of dissection somewhere in the mid periphery or at the posterior pole. So as we see in this case, there's extensive fibrovascular membranes which are present. Now we do enter into a plane, but if you see this sheen which is coming here, where it's marked by the yellow arrow, this basically tells us that probably we are not in the right plane. So this sheen is also a very important clinical indicator or surgical indicator that I look at. And then you go back and grasp again, and there you find that you finally entered into the right plane. And after you're into the right plane, I think it's just a matter of time, and without any more iatrogenic, any iatrogenic breaks or extensive bleeding, you can probably finish your case. So what makes the surgeries, what makes PDR more morbid? It is definitely the extensive fibrovascular proliferation. I think very tight, adherent posterior hyaloid. I think personally what I feel is sometimes you'll look at a case and look very simple, but then this very, very adherent hyaloid, especially in a retina which is attached, and you prognosis is good. I think adherent amyloid is extremely tough. And again, the role of vitreous knowledge of vitreous is very important here. Again, then dense clotted heme also makes it extremely morbid. And dense vitreous hemorrhage, definitely when you don't know what is there behind, I mean, obviously the situation is morbid. And to top it all, I think a detached retina adds to the confusion. So I think with morbid PDR, where preoperative assessment is not possible, then I think there are no definite rules as such, but then I think you should go by instinct, follow the rules that have been taught over the years, and slowly and gently kind of cleave your plane through. So if we see this case, I think there's extensively dense vitreous hemorrhage. There's nothing that you can see. There's a kind of a heterogeneous kind of a glow. I think you go layer by layer, keep your cutter up. I think the cutting edge should be up, and kind of go layer by layer and kind of clear the vitreous hemorrhage. After that, I think important to start bimanual dissection and try to find your plane through. I feel that you should kind of probably study the crust and the troughs and kind of align your scissors in that way. And I think the best tip would be to kind of follow the topography of the membrane that you see, or the next step that you see. I mean, there are obviously high chances that you might end up with a nitrogenic break, but then it's okay in situations like this. I think you need to keep your morale high and kind of, tackle your way through. And ultimately, even when these cases feel that they are never ending, I think there are times when, you can successfully kind of complete these cases without much trauma. There are other situations which make the case morbid. Those are those anterior extensions of fibrovascular polyps, then coexistent macular hole or RD with PVR. And so in this case, we see that so this person basically has a fibrovascular polyp along with the associated macular hole. And so as routinely, we kind of dissect our membrane bimanually. And now very important is that when you start the ILM peel, we would prefer doing the with the forceps. I think Tano does not work too well because I think the macular edema is there and it's very boggy. And I think it's important that you go from outside in and not go from inside out, because there's a huge tendency that you might just kind of make the hole more larger than smaller. And so I think gently kind of remove the ILM, and the force should be tough enough, but quite slow. This was one more thing that I wanted to show, which was basically a bimanual endodiathermy. I think this helps because it helps us in not increasing the bottle height too frequently. So basically you can hold a backflush needle in one hand and relieve the hemorrhage, and you can very clearly pinpoint the bleeder and then cauterize it. So this is one more case of anterior prolif. I wanted to show this case because I think in this age, I don't know how many of us are really using these contact lenses, but I think a contact lens really helps, especially the prism lens in these mid-peripheral areas, and you get a very good view, and I think it makes the surgery much more easier and much more comfortable, and you can completely remove these prolifs very well. This is one more case which has been done. I think we did it just a few days back. And this case, I think, tops it all. I think it has a combined detachment. And before I start the video, it had a combined detachment. It had this very bad prolif which was pulling up the macula. And there was actually one attachment which was directly at the fovea. I think the detachment was extending probably, I think the inferonasal to 12 to 8 was the only area which the retina was attached. And there was a break in both the quadrants in that area. So it was extremely difficult for me to, for us to kind of go, complete the PVD, enter the hyaloid from the nasal side. So in this case, I think we thought a little different, and usually we like to go from outside in, but in this case, because the hyaloid separation at the base was not possible, so we debulked the hyaloid and then started going in from the inside out. So after finding a cleavage plane over here, we kind of were able to kind of remove the membrane, and I think very gently and with a lot of patience, I think we were able to remove the complete membrane. And then this dissection was happening over a pre-existing break which was there. I think it's important to kind of change your ways at time, because in this case, if I would have ended up with a very bullous retina, I think it would have made things extremely messy. So then slowly we kind of remove this membrane, and then we extend the hyaloid till the base and complete the base excision also. One more tip is that I think if you're not able to find a plane, surgical plane in the periphery at the first go, I think it's important that you debulk the base at least before you start membrane dissection, and then you can have an attached retina. So just to summarize, I think adhere to the surgical principles. I think however simple or tough a case appears, I think always be prepared to adapt in these tough situations and alter plan according to the need on the spot. And I think perseverance always definitely plays a very important role. Thank you.
Thank you so much, Dr. Gagan. That was again excellent demonstration of the principles of PDR surgery. I would now like to call upon Dr. V.R. Saravanan. He's again one of the fantastic surgeons that we are lucky to know and to have watched his surgery. Dr. Saravanan works in Arvind Eye Hospital, Coimbatore, and he'll be talking to us about the intricacies of pediatric retinal surgeries. Over to you, sir. I think you're muted, sir.
Yeah, sorry. I have to view my slides now.
Yes, sir.
Yeah. Are they progressing?
Yes, we are doing.
Okay, thank you. So we saw a lot of nice videos and surgical descriptions of how to operate on adult eyes. But when you're dealing with the children, especially it ranges from anything between 0 to 18, but in our hospital is less than 16 usually. So there are a little bit lesser indications, and one thing we have to keep in mind is a different anatomy, and obviously the varied prognosis depending upon the disease and the stage at which the patient presents to us, to the clinician. And also we have to, very important is the post-operative care as regards to the visual amblyopia treatment and all those things, refractive correction and amblyopia treatment is very critical. So things to note is that the very short axial length, especially in a very small baby like an ROP, the presence of the large lens in comparison to the vitreous cavity, more stronger vitreoretinal adhesions and other congenital anomalies which may be there. So apart from this, the parents have to be realistically counseled on what to really expect out of this surgical outcome, what is the functional outcome, all those things have to be clearly mentioned. So the main thing we have to try to deal with in our hospital is the retinopathy of prematurity, familial exudative retinopathy, RDs, Coats disease occasionally, retinoblastoma occasionally, JXLR now and then, and also the persistent fetal vasculature. Retinopathy of prematurity, we plan for surgery when the disease progression is noted in spite of doing adequate laser and cryotherapy occasionally. And also in patients who present later with stage 5. And obviously you have to keep in mind that the functional outcomes of stage 5 ROP, even the anatomical outcomes are approximately 20% and not that very great, especially in anterior and posterior closed tunnels. So in stage 4, both in RDs involving the macula and not involving the macula, stage 4 and A, B, sometimes you may be able to get away with placing a scleral buckle, which is usually a 240 band held with the Vicryl switches. If you're using other permanent switches, you may have to release it at 3 months. But 240 with Vicryls usually is enough, so you don't need to do a second surgery. This mainly helps in remodeling the fibrotic elements and changing the direction of the tractional forces, and it's placed at the maximum ridge height. In stage 5, with the anteriorly open or closed funnel, then obviously you have 3 choices: pass-panel vitrectomy with enceptomy, pass-panel vitrectomy without enceptomy, and occasionally when open scan vitrectomy when there is a corneal opacity or a scar. So one thing you have to keep in mind is in both the orbital fissure, the space for maneuvering inside the and outside the is quite cramped. You need a little bit of learning curve to accommodate to all these difficulties. Various traction elements which you tend to see here is the ridge to ridge, ridge to lens, ridge to the disc, and also ridge to periphery. There are around 4 types of traction, and at least most of these traction should be relieved to a great degree to get some sort of anatomical success in these cases. So as again to highlight the space constraints, the axial length is hardly 16 millimeters, vitreous volume is hardly 1.5 ml, and ciliary body is quite flat, and you have to enter quite anteriorly in these eyes. And this is the site of entry. Depending upon the age group, at very less than 6 months, you go at 1 to 1.5, depending upon whether you're preserving the lens or not. And till 1 year, you go 2 millimeter. Till 2 years, you go at 2.5. Until 6 years, it's 3. And after 7 years, it's almost like a adult eye. This is a case of lens sparing vitrectomy in stage 4B retinal detachment. You can see we're placing the 25 gauge cannulas quite anterior near the cornea limbus. And you can see the mainly we are talking about the release of the traction. Here our aim is not to do a full vitrectomy, vitreous-based shaving or PVD induction. Mainly we aim to relieve all the significant tractional forces. First to deal with the anterior posterior from the PC to the disc, and then the tangential tracking forces, try to avoid retinectomy as far as possible. So how far you can avoid all these things? So you do a limited vitrectomy, just taking care of all the significant traction, not aiming for a total vitrectomy. This stage 4, stage 5, again, where the lens is removed. You can see now the placement of the infusion in the anterior chamber and all the cannulas in the anterior chamber. And first doing a lensectomy and then going on with a bimanual technique, using 2 sharp needles to create the first rent in the membrane. And once you get the plane, you can switch to forceps and scissors and try to deal with this. So once you deal with the central funnel, you can, if there are other peripheral elements, especially the temporal ridge, you can take care of that and then put visco to keep the folds apart. This is a rare case of fibrosis secondary to stage 5 ROP. Cornea is totally fibrotic scar is there. So on a totally anterior and posterior closed funnel, yes, you are doing putting a Piranga ring and then draining the subretinal fluid to create some sort of space. So, and then doing removing the graft, and then going ahead with the removal of the lens, and then it becomes more or less routine, removing all the anterior membranes and then opening up the funnel, injecting visco to keep the folds open. So sometimes in stage 4B, using a triamcinolone can help to delineate the posterior hyaloid a little bit more easily, especially the presence of multiple skytic layers. So this can help to, triamcinolone may be helpful in identifying various skytic layers in the posterior vitreous cavity. As regards to FEVR, 2 indications. One, it can be a TRD affecting the posterior pole, and second can be a REG-RD because of peripheral breaks. So what mainly we have to keep in mind here is the strong adhesion of the vitreous at the edge of the peripheral avascular zone. And sometimes because of the contraction of the peripheral fibrotic elements, you may have an anteretinal displacement or anterior retinal pull. Sometimes even the pars plana is totally obliterated. So if you're not aware of this, when you're placing the infusion, it can go subretinally, causing worsening of the RD. This is a case of a tractional one-eyed person. He is around 15 years old boy. Other eye is even more worse than this. So this is the better eye, and he had a recent drop in vision. And you can see here our aim is not to remove the whole vitreous because the vitreoretinal adhesions are very, very strong. So on the ridge is quite pulled and totally distorted. So we're trying to mainly free the posterior pole and trying to not address the peripheral vitreous because it's almost impossible to remove the peripheral traction elements away from the retina. They are strong, very strongly adherent at the edge of the peripheral avascular zone. So trying to open up the macula and trimming off some of the vitreous. We cannot try to remove this. If you're trying to remove this ridge membrane from the ridge, it's going to go into significant tears, which will totally worsen the prognosis, especially being a one-eyed patient. This is one more, I think, 7 or 8-year-old girl who came to us with the REG-RD. The right eye was the better eye. I think this is the left eye. So it has got a temporal large fibrovascular mass with associated small break next to the fibrovascular mass. So you tend to see this fibrovascular mass in some of the severe types of FEVR. So here in most of these pediatric RDs, especially because where you're not able to address the peripheral vitreous considerably, placing a supporting buckle will really help to release these peripheral tractional forces. And this is the, you can see this is the totally pulled up retina temporally, and this is the break there. That is the break there. So it was quite nicely lying on, and that's the fibrovascular mass just inferior to that. So otherwise it progresses like a routine surgery. Only thing, the peripheral vitreous is not easily peelable, and we try to support this with a peripheral scleral buckle. Course disease, usually the mainstay is laser or cryotherapy along with intravitreal steroids and sometimes anti-VEGF. But surgery may be indicated in some of the very severe forms where the parents are not willing for enucleation. Here you can see that's mainly like a scleral buckling surgery, but only you don't place a buckle, you do the external drainage. And this can then be followed by, you can see this sample is being taken to just rule out whether it's diffuse infiltrative retinoblastoma or just a coarse disease, the sample can be done for histopathologic examination. And then, so once the retina becomes flat, you can do on-table itself cryopexy to all the vascular elements. You can see there's fibrotic elements of subretinal and cannot be removed. That's so it's more palliative than a visual. So it's mainly to prevent enucleation in these eyes. So pediatric regarding some of the consideration is that there may be no PVD in a lot of cases, and sometimes even in what looks like a PVD, you'll have a very thin sciatic posterior hyaloid vitreous, which is very thin and transparent, very difficult to identify and remove. Because if we don't remove this, then it's going to cause later complication recurrence. So again, a lot of these cases you see that the vitreous base, especially in the sticklers and all these syndromic RDs, the posterior vitreous base is very, very posterior, sometimes even posterior to the equator. And here you have a significant role for, I can see just showing the very posteriorly migrated vitreous base. It just be beyond the arcades, very much posterior to the equator. You cannot separate the vitreous. Trying to pull on these vitreous is going to create multiple retinal tears. So you have to stop here and trim it and support these areas with buckle. If it is too tense and tight, then you may have to do a retinectomy like the previous speakers as they showed. And also in a mobile retina, especially inducing a PVD is I think 4-year-old Marfan's baby with a dislocated lens and a total RD. Lens was removed, and then you can see in a mobile retina, it's sometimes because you don't have the counter traction of the stable retina, it's difficult to induce a PVD. Sometimes most of the time I use the bent sharp needle, 27 gauge needle. We are doing 25 vitrectomy, gauge vitrectomy, and rubbing along the retinal surface will hook onto the posterior hyaloid face and induce the PVD nicely. So this is quite helpful. This instrument is quite helpful in inducing PVD, especially in mobile retina and pediatric eyes. Retinoblastoma, I mean, it's very, very rare to get surgical indications in these, but sometimes you can get breaks due to excessive laser or cryotherapy, and sometimes because of the surface fibrosis on a regressing tumor. So these are two cases I want to show. Unfortunately, I cannot get the videos, but this was the presentation, and this is the right side. You can see the following laser around that, and cryotherapy, you can see that the tumor has regressed, but this is the scar. We've developed a small break at the edge of the scar, and the RD is now extending very close to the fovea, just above the fovea. So fovea is still attached with the good vision, but it may get involved anytime. Dr. Parag tried to do a barrage, but it was not contained, and we had to go for a vitrectomy. I did the vitrectomy, and this is 2 years follow-up. You can see the nice regressed tumor with the laser scars, and gas was injected in this baby, and luckily is maintaining 6-12 parts in this way. Otherwise, has been enucleated for a severe disease. This is one more case where there is significant surface fibrosis producing a significant large break just superior to the tumor on the nasal side. And again, Dr. Parag tried to address this by doing a barrage, but again it went into a total RD within a month, and we can a little bit you can see the very significant PVR changes. And again, we have to do a retinectomy and tumorectomy in these eyes and fill it with silicone oil. So there are some cataracts, so the view is not very clear, but now the retina is still attached nicely, and you can see the cut tumor on the edges of the scar, laser scar. So last case indication will be the PFV or a persistent fetal vasculature. Again, most cases are subtle and don't need are away from the visual axis, and they are not they don't need to surgically be intervened. But sometimes when there is significant profound loss because of visual opacity, axis opacity, then you may have to go in for surgery in these patients. So only thing you have to keep in mind is proper assessment of the various structures, both anterior and posterior. I just show the video on if you're doing anterior thing, you always better to sacrifice the lens because the ciliary body is considerably altered, and sometimes you produce a secondary tear. So I try to usually sacrifice the lens in these eyes, and usually they are amblyopic because of the shorter axial length. And when you're operating the posterior, then you have to make sure that you don't cut the central retinal artery, which can sometimes loop into the stalk. You may be creating iatrogenic CRAO. This is one of 27 gauge vitrectomy in a case of PFE with vitreous hemorrhage. You can see the dense vitreous hemorrhage, which is being cut down, organized hemorrhage. And it's not right to remove that fully like you would do in a PDR patient, because that's going to compromise the retinal circulation. So JXLR, we'll show this video and finish it off. So most of the times it's simple, you can get away with the buckle, but sometimes when in very stiff eyes, you may have to do a retinectomy of the inner layer to release. You can see the air is going under the vitreous, between the two layers of the retina. And we have to do a retinectomy to sort of this thing. Thank you.
Thank you so much, Dr. Saran sir. Excellent collection of wide variety of pediatric pathologies, and I'm pretty sure everybody is aware that pediatric cases present a unique and a difficult challenge. Thank you so much for elucidating the principles. I'd now invite Dr. Dhanashree Ratra to talk about extreme trauma. She's one of the VR surgeons who, some people learn surgery, some people have a flair for it. So she is one of the people who has an extreme flair for retinal surgery, and she's practicing as a senior consultant in Shankar Nethralaya. Please go ahead, ma'am.
Thank you, Abhishek, for your kind words, and thank you for inviting me for this lovely instruction course. I have been enjoying these wonderful videos and excellent surgeries, and I would also like to thank Darius for his help with this presentation. So I'm going to talk to you about extreme trauma, and extreme trauma can be really challenging to handle. However, I'm going to give you just broad outlines. This is you must be aware of this trauma classification, which has now been adopted by the Trauma Society, and it is quite a simple trauma classification, and it is actually good to classify your cases into this classification so that you can compare outcomes and also help in predicting prognosis. So even before you do the primary repair, you must look for the vital signs or any bony injuries or any associated facial ENT trauma. And if you do see any unstable vital signs or impaired mental status or any serious non-ocular injuries, then these take precedence over the ocular injuries. So these must be referred for proper management to proper hospitals. As far as the eye injury is concerned, you must take detailed history, especially the circumstances of the trauma and what exactly has hit the eye. You can do a quick examination, either slit lamp or even a torchlight examination. And if there is a frank open globe or foreign body, then the surgery is a must. If there is uncertainty, imaging can help in ascertaining whether there is an open globe. And even after imaging, if there is still uncertainty, an exploratory surgery can be done if necessary. Now, when to intervene for vitrectomy is a big, debatable point. Whether you should do vitrectomy at the time of primary repair. So the pros for this is that there is no fibrovascular proliferation at this stage, and there is less chance of infection if you plan to do a vitrectomy at this stage. But there are a lot of disadvantages of doing vitrectomy at this stage. So first of all, you have poor visualization. The tissues are all inflamed and edematous. We are unable to see the just a second, please. We are unable to see the posterior segment well, and sometimes even assessment is not possible. Also, but there is a possibility that if you wait for too long, there can be proliferation of fibrovascular membranes inside the eye. So any vitreous incarcerated along with presence of blood and lens material can give rise to progression of proliferative membranes, and these can then exert traction either on the retina or on the ciliary body, or they can form a pupillary membrane. So you need to intervene before this stage. So let us look at the indications for early, intermediate, and late interventions. So early vitrectomy, that is within 72 hours, is required if you suspect endophthalmitis, presence of toxic intraocular foreign bodies, or retinal detachment. Late vitrectomy, that is between 3 to 14 days, is done for retinal detachment, lens injuries, severe vitreous hemorrhage, double perforating injury, or intraocular foreign body. And a delayed vitrectomy is possible if you have just a pupillary membrane, a dislocated lens, ghost cell glaucoma, RD with PVR, macular pucker, or simple vitreous opacities. A preoperative evaluation is a must. You must ascertain perception of light, and sometimes a BEP can help if you are not able to ascertain whether patient can see the light. Consent and a proper counseling is very important. Associated injuries, especially the anterior segment, must be evaluated, and you must see whether it is possible to have good visualization, as you can see these few examples here. And so if any combined surgery is necessary, such as a cataract removal or iridoplasty or penetrating keratoplasty or scleral fixation, that can be combined with your posterior segment repair. Posterior segment assessment is often difficult in such cases, and there comes the role of imaging. Imaging can help you ascertain the retinal status. It can ascertain whether there is any posterior globe rupture. The vitreoretinal relationship can be ascertained by imaging. Presence of foreign body, a dislocated lens or IOL can be determined, as well as choroidal detachment. Now, this will help the surgeon in planning the surgery, getting the required instruments ready, such as, say, for example, a foreign body forceps or a magnet, and it will also help in prognostication. So these are examples. Here you see an ultrasound with total RD with PVR, and a CT scan construction where you see bony injuries, fractures. And here you can see a foreign body right at the macula, which can definitely help you explain the bad prognosis to the patient beforehand. So the general principles of surgery, here I would like to show you this cornea, which is badly damaged, but still it offers a good view of the posterior segment. So you can attempt surgery even in such eyes, but it is very important to ascertain a watertight globe before you start your posterior segment repair. And here you see that the wound is leaking due to some incarceration or iris and vitreous there. So it is important that you first suture the wound and make it watertight before you proceed with your vitrectomy surgery. Sclerotomy planning is a very essential, and you must pay meticulous attention to the position, the site of sclerotomy. It should be at a safe distance from the repair wound, and at the same time it should have a good access to the wound as well as to the posterior pole. Infusion cannula placement is also very important. One must avoid sites of large parallel detachments, and if you suspect parallel detachment, then a 6 millimeter infusion cannula is better. Otherwise, you can also use an AC maintainer like this, or even a bent infusion cannula. Now, oftentimes when you perform the sclerotomy in traumatic situations, you can see this egress of this bloody blood-tinged fluid. This is nothing but the liquefied suprachoroidal hemorrhage, which is often present in traumatic situation. So here we are actually fixing a 20 gauge infusion cannula. This sometimes can help. Probably there must have been some reason, maybe it was not available, the 23 gauge cannula, but the rest of the sclerotomies are 23 gauge. Now, once you go inside, you can see how difficult it is to do surgery in such a situation where there is just a mass of tissue inside, and it is impossible to determine which is vitreous, which is a membrane, and which is the retina. So sometimes the bimanual surgery with a chandelier can definitely help. It should be definitely, you should first make sure that it is not the retina before you cut any tissue. And after this is a result after a meticulous surgery, after 3 hours of surgery, you can see the retina is now somehow at least visible and attached. Detachment of posterior vitreous is an important step in any surgery, and it is recommended for all surgery. However, it can be very difficult, and especially in young children. And if there is a pre-existing fibrosis or retinal detachment, you have to be even more careful. But if you leave a residual vitreous, that is also not good, because that will eventually contract and cause fibrous proliferation and lead to recurrence. This is a situation where you can see that there is a dense red vitreous hemorrhage. It is totally adherent to the retina. The retina is also totally detached, and the view is also very poor. So it makes your life very difficult. You have to be very, very careful. You go layer by layer in removing this blood, at the same time trying to not damage the retina. So at all times you need to be careful. Now, Dilraj already touched upon this subject, but many times you will come across situations where you can have vitreous or retinal incarceration. Do not pull the vitreous from the wound and leave it to plug the wound. That is better. And just trim around this incarceration in a vitreous incarceration. If you have a mild retinal incarceration, then again you can just barrage it and probably support it with a buckle. For severe incarcerations, you can cut the retina and do laser around it. So these are a few situations where extreme traumatized globes, but they have settled well. Nearly about 18% of posterior segment trauma will have intraocular foreign bodies. Imaging is vital, and reactive foreign bodies such as iron or copper, which can cause siderosis or chalcosis, need to be removed. Non-reactive foreign bodies such as glass or plastic, if they are very small, can be left behind, but however, they can cause mechanical damage. And vegetative matter will lead to infection, so that we have to remove. Considerations in the removal for foreign body is you need to be very certain about the location of the foreign body, whether it is intravitreal, on the retina, or subretinal, whether it is magnetic or non-magnetic, and which route of the foreign removal that you can take for this foreign body removal. This chart will a little bit explain to you how we can remove the foreign body. In all situations, you must do an indirect ophthalmoscopy at the end to look for any peripheral breaks or dialysis. In case of intravitreal foreign bodies, you remove the vitreous around the foreign body and then remove, if less than 5 millimeters foreign body, you can remove it by enlarging the sclerotomy. For magnetic, it is very easy. You can use a magnet. For non-magnetic foreign bodies or large foreign bodies, you can remove them through limbus. And sometimes you may have to even sacrifice a clear lens in such a situation. If you have a foreign body on the retina which is encapsulated, then you may just cut open the capsule and tease the foreign body out of the capsule. Do not bother to dissect the capsule off the retina because it is quite impossible. If you have any retinal holes, then it is better to laser the holes before you remove the foreign body. In case of subretinal foreign body, it is better to remove it from an external approach and give a support by scleral buckle. So these are two situations where you see extreme trauma. There's a large bullet, large inside, and there is no other way to remove it but by open sky vitrectomy. And so this is being removed through open sky, and then donor cornea is sutured onto the eye. And this is another situation where already attempted surgery has failed to remove the foreign body. So this is the second attempt where we are again going inside with a 20 gauge MBR knife, and you see a large cuboidal glass foreign body lying on the retina. Glass foreign body is little difficult to grasp because it keeps slipping. So here we are using a foreign body tongue-like foreign body forceps which can open wide, and this is being lifted up into the anterior chamber. So this already limbal section is there, so you need to cut open the limbal section so that you have a broader access for removal of this foreign body. Generous viscoelastic will help in protecting the endothelium, and then this foreign body is being delivered through the limbal route. So luckily this foreign body could be removed safely without damaging the retina. Suprachoroidal hemorrhage is often present in traumatic situation, and it can be dealt with similarly in other situations. However, a 2-week interval is better to wait in case you don't have any other problems such as severe retinal injuries or glaucoma. Post-traumatic endophthalmitis, I will not go into detail because Abhishek will be covering it, but it is the risk factors are delayed primary wound repair, presence of foreign body, and a ruptured lens or capsule. A note about no light perception eyes, what to do with these eyes, whether to attempt surgery or no. So first of all, rule out these 3 things, that is optic nerve avulsion, optic nerve transection, and profound loss of intraocular contents. If these 3 are present, then definitely there is no chance of regaining any vision and you can leave these eyes. But however, otherwise, if it is severe trauma, you can attempt repair. Sometimes about 4 to 33% of patients can recover some vision. And so this is one paper where they have shown about 23% recovery in such eyes. So value points, I would say that is often less than ideal situation. There are many challenges and improvisation is necessary. You may have to think on one's feet and ready with a plan B. Expect the worst, always try to save the globe, and wound repair should be attempted even in a bad way. And best time to intervene is about 10 to 15 days after the trauma. And although there are varied outcomes, but sometimes useful vision can be salvaged. Thank you.
Thank you so much, ma'am. And with that, we come to the last talk of today. And I'll be talking about fulminant endophthalmitis and how we go about salvaging the eye. Now, fulminant endophthalmitis is SOS basically from the eye, and unless you are really aggressive, you can lose the eye very, very quickly in spite of your best efforts. So I have no financial interest to declare. Now, where do we see fulminant endophthalmitis? We see it sometimes when you have post-surgery endophthalmitis that is progressing rapidly, either because of the virulent organism. Sometimes in post-traumatic cases, you have unusual organisms, or it is a polymicrobial infection, and that along with the comorbidities spreads really fast. Sometimes endogenous endophthalmitis that we see in patients with compromised immunity or drug abuse, or sometimes even in neonates, is quite fulminant. And a lot of times post-injection endophthalmitis, we've had incidents of counterfeit medication, and these cases usually get delayed attention because it's not a surgery. Patient goes home and comes to you quite late. Some traditional surgeries, especially by quacks, can also lead to very bad kind of a picture. Now, what leads to poor outcomes and endophthalmitis? One, of course, is the highly virulent organisms, and the second is drug resistance, which we are seeing more frequently nowadays. These are aspects that we need to tailor our therapy accordingly. Late presentation and delayed diagnosis can also result in poor outcomes, and a lack of timely specialist support or appropriate instrumentation can lead to loss of the eye. A lot of times, inadequate drug concentrations or control of inflammation and the associated complications present along with the endophthalmitis can also cause trouble. Now, the aims of treatment are: number one is to sterilize the eye, number two is to control the inflammation, and number three is to assess the comorbidity. Then we'll be looking at that now. Sterilizing the eye, microbiology is of paramount importance. You need to use all that is available at your disposal, including routine microbiology and PCR techniques to find the bug. Unless you find it, you will not be able to neutralize it. Vancomycin, ceftazidime, of course, is the first line, and for fungal, amphotericin B is supposed to be better than voriconazole for post-traumatic cases, especially. We have to be very quick in antimicrobial escalation in cases of fulminant endophthalmitis. Linezolid for gram-positive, piperacillin tazobactam plus or minus colistin is usually employed for gram-negative, and for fungal, either voriconazole or caspofungin can be employed. So in case you do not see the desired response to your antibiotics, the routine antibiotics, escalation should be pretty fast. Also, early surgery is a must. If the media permits, and even if there is a severe inflammation, you should go for early surgery. There is an increasing trend with the instrumentation to not wait conservatively with endophthalmitis. And if there is a comorbidity like RD or a foreign body, then of course there's no question you have to go for early surgery. If the media opacity is such that you cannot operate, then of course you defer it. If you have choroidals, you may wait for a couple of days, or if there are certain other systematic factors in the patient, then you may want to defer the surgery. Severity of endophthalmitis is basically the severity of inflammation. So inflammation is to be controlled with the utmost aggression. Macular edema, membranes, retinal detachment, and hypotony are all long-term complications that can happen even if you sterilize the eye, but you fail to control the inflammation. So vitreous acts as a reservoir. That's why early vitrectomy with a PVD induction and a vitreous lavage multiple times, sometimes AC wash, is essential to reduce the inflammation, and systemic and intravitreal steroid need to be given fully as and when required. Now, this is, I'm just going to present one video in my talk, and it highlights several principles. First, in fulminant endophthalmitis, sometimes your view may be really bad and you don't even know what your landmarks are. You sometimes see a faint shadow of a disc and you get your orientation from there. And sometimes you may see certain collections of exudates that you may mistake for the disc. So you are basically on your own, especially if it's also complicated by trauma. You may have heme, and that further confuses the picture. So one of the key identification marks is the presence of vessels and of branching of vessels that leads you to go back and identify the disc. And from there, you can carry on your surgery. If you have a lot of inflammatory membranes on the retina, it is probably best to induce a PVD. And I personally prefer to induce PVD in all my cases of endophthalmitis. And in this case, this patient had a ricochet injury. This had a foreign body and a ricochet injury just below the disc. And if you see here, I'm trying to gently induce the PVD. Now I'm at least able to see the disc, and those are the collection of exudates around the blood vessels. Now, this shining thing you see, this is the foreign body. Now, before I attempt to actually take the foreign body out of the eye, I am trying to attempt a PVD. Now, sometimes when there is a delay, in a case with endophthalmitis and foreign body, there may be fibrous bands also. So here, as I am inducing the PVD, I'm going very, very gently, removing whatever little bits and pieces of the vitreous that I can. And now here we see that when I'm inducing the PVD, probably there was a small break which got enlarged, or maybe that incarceration that got freed from there, and that has resulted into this break and bleeding. Now, this is the time that you don't panic. This is the time that you don't panic, and the best course here is to go ahead and do the surgery that is possible, in the sense that don't try to complete everything in a single go. So here I freed the break from all the vitreous all around. And after freeing this, I go ahead and induce the PVD gently further till the mid periphery. This is what it looks like after I am satisfied with my vitrectomy. We of course then go ahead and remove the foreign body. Yeah, this is the foreign body lying on the retina in the inferior periphery. We identify that, pick it up with a magnet and use a handshake technique and transfer it to the foreign body forceps and remove it out. Now, what next? How do we address that hemorrhage and the break near the disc at the posterior pole? So this is another point that I want to make. You don't need, like I said, you don't need to do everything at the single go, especially in cases of fulminant endophthalmitis or in cases where the view is really bad. You can do a stage surgery. So in this particular gentleman, we had put in oil, and this is the follow-up that you see over a period of time. In approximately 1.5 months, the heme has gone away, and actually what appeared to be a fairly large hole has actually shrunk and become a very small area. And approximately 1 month, we did the laser around the break, and it scarred. And this is the patient. This patient achieved 6/6 vision at the end of the follow-up. Another important thing that we very routinely do, I do it in almost all my cases of severe endophthalmitis, is a two-port lavage. We do a core vitrectomy or a first intervention, and we remove most of the vitreous along with the inflammatory exudate. But then, like I said, it is infusion that kills in endophthalmitis. So every single time that 48 hours, when we repeat the intravitreal antibiotics, I take in a IV line connected to a bottle, connected via 26 or 24 gauge needle. And on the opposite side, I again introduce a 26 gauge needle at the pass plan and just start the flow. And I keep waiting there for patiently for at least 4 to 5 minutes. That makes sure that at least all the vitreous cavity fluid has been exchanged 2 to 3 times with fresh fluid. Not only does this reduce the bacterial load or the inflammatory load, it reduces the cytokines and the deposits that are happening at the macula. So you have a milieu that is now less, that has less inflammatory cytokines, less muck than before. It improves your view also. And at the end of this procedure, we take out both the needles and then give the intravitreal antibiotics as usual. Handling comorbidities is the third and rather final thing which will help you save the eye. If you have corneal issues, especially in foreign body, you have an entry wound, you do imaging if you have an entry wound. If there are lens issues, you have to remove the lens and you have to handle pure poor view. For corneal issues that are unsurmountable, when the scarring is too much for you to see anything, then you may require to use the temporary keratoprosthesis for surgery. You have Lander's keratoprosthesis available that can be sutured on and then later on at the end of surgery replaced with a graft. Do you do a complete vitrectomy? I always induce a PVD at least up to the mid periphery, but I usually do not do a base excision because the retinal thickness routine anatomy states that it is very thin, and a lot of the inflammatory muck is there, and there may be necrosis of the retina or inflamed retina there, which is very prone to tearing. So I am not in favor of extensive vitrectomy, even though some people say it reduces the microbial load and the substrate for vitreous growth is removed. Well, this is not true. If you go for the math, even if you just leave 1 million organisms per ml, which is hardly anything at the end of your extensive vitrectomy, by the end of 20 years, you're going to have 1 billion organisms again per ml. So you really don't do much by doing just a complete vitrectomy. And vitreous is not blood agar, basically. Bacteria and fungi grow very well in BSS also. So just filling the eye with BSS, removing the vitreous is not going to help. Also, there is a school of thought which says that put in silicone oil whenever there is severe endo, because some people have proposed that it has antimicrobial activity. Some people say that it prevents detachment and improves media clarity. However, I am actually not in favor of this. We did an experiment, where we designed these wells in nutrient agar. We made these wells which are the size of our eye, that is 24 mm diameter. And then we filled this with half of them with silicone oil and half of them with BSS. And we inoculated them with cultures of bacteria and fungi. And see, this is Staphylococcus. It grows very well under oil also. In BSS also it grows very well under oil. Gram-negative organisms grow very well under oil. They easily coat the whole of the agar surface. And this is Candida under oil. So oil does not have any anti-microbial effect per se. Also, the problem is that vitreous, vitreous is not an impediment in the intraocular spread of antibiotics, but silicone oil is. And there is sequestration of all antibiotics, sometimes antibiotics in oil when you inject inside oil. More so, whenever you inject oil, especially in an inflamed eye in poor visualization conditions, you're not very sure of the silicone oil fill. These are MRI images which show that the amount of fluid behind the silicone oil in so-called proper fill is quite variable, and you have absolutely no idea of the fluid compartment, and you may go very grossly wrong with your calculations of antibiotics and have toxicity. So the other thing that I want to highlight is multiple surgeries. Surgical target in one sitting, it may be difficult, it may also be undesirable. So sometimes it is better to defer certain steps for later when your infection is under better control, you have better view and lesser inflammation. Thank you. So the point I wanted to make was that, not everything can be achieved in fulminant endophthalmitis in one go. Whenever you see a case, you always have to inform the patient that he is up for multiple surgeries, and you go in a stage-wise manner to make sure that you get the best outcome possible. Thank you. Right. So any questions? Dr. Vishwas, do you have any questions on the forum from the attendees?
Sir, nothing that I see on the chat or in the Q&A box. So,
Right.
Nikhil, do we have any more questions? Because here I cannot view any.
So, right, one question I have for all the panelists, I think whoever has tried it can pipe in. What about PFCL tamponade? Dr. Darius had talked about tamponade with heavy silicone oil, but as we all know, it's hardly available. So what about PFCL? Is anybody using PFCL for a medium or long-term tamponade in cases with inferior PVR or with recurrent RD?
Yes, Abhishek. You can use PFCL as an inferior tamponading agent in the presence of break. Steve Charles was one of the popular proponents of this technique. I have done for a few cases. Only thing is you have to make sure that the patient is very compliant, is able to come back for follow-up at the correct time. Either you can remove the PFCL and put in full fill of oil, or you can, if you feel the adhesion is strong enough, we can even go for a short-term gas tamponade also. But I usually reserve it for some of the rare cases rather than doing it as a routine. I think Madurai people, Dr. Naresh does this as a more or less routine in severe cases. Every day, I think he does some of these cases actually.
Dr. D.D. ma'am, are you using PFCL?
Yes, but I use it only as an intraoperative tool, and I don't actually use it as a short-term or intermediate-term tamponade. However, it can be used, theoretically speaking, it can be used, but one must keep in mind that it needs to be removed, say, after 2 weeks or so. Otherwise, it can lead to inflammation. So, if that is done, then probably it might help. As Saravanan said, in severe cases, it might be beneficial.
Right. Dr. Dilraj, are you using PFCL there? I mean, for intermediate tamponade? I should say intermediate tamponade, because most of us, I think, use it for 2 to 3 weeks. I think Dr. Dilraj is not here. Any other questions that anybody in the panel may have, or any point that somebody would like to add in? And I think we can go ahead with that.
If Darius is online, I would like to ask whether he uses any chemical, like 5FU or low molecular weight apparent for decreasing the incidence of post-operative, what do you call PVR.
I don't use any of this. I mean, I think I don't really believe in it, but I think there's a new study with methotrexate is coming in from US. In one of the Stanford symposium also they spoke. So it's a good thing. In the future, it may be useful. Are you using it, sir? Are you?
No, no. I have read about it, but somehow I have used Tramslone trying to inject at the edge of RR and sometimes leaving some in the vitreous cavity at the end of surgery. I found that was not of much of help in preventing PVR. I was not happy with the Tramslone. I have not used. I have seen people in the US using 5FU and sometimes other things also, but personally I have not used.
Triamcinolone, I think I always like inject liberally, and I don't make an effort to remove it also. That's, I believe it helps a bit, but I mean, we have no, it's just anecdotal. I don't think we've done any study on that.
Right. Thank you so much for all the speakers for today. I think we had an excellent session, and I'll now hand over the hall to the next session. Thank you so much. I would like
Thank you,
to
sir.
thank all the members.
Thank you, Abhishek, sir. Wonderful session.
Thank you.
So one request before we conclude the session, can we take a quick screenshot?
Please go ahead, sir.
Am I right, Dr. Priyam? That would help, right?
Right, definitely.
I can see Dr. Priyam smiling under the mask. That's the important part. All right. So I would request all of you to smile in 5. Dr. Kamaljeet bhi aa rahe hain, 1 second. 3, 2, 1, and here we go. Perfect. Thank you.
Thank you
so much.
everybody. Bye.